Welcome back to Corium. I'm Brian Gilberti, and today we're joined by one of our rock star senior residents, Aurnee Rahman. It's great to have you on the podcast, Aurnee.
Thanks so much for having me.
So recently, during Morning Report, we presented a case of necrotizing fasciitis that sparked an important discussion. And this is a condition we must always be on high alert for because time is of the essence when it comes to diagnosis and treatment. Now, soft tissue infections are something we encounter often in clinical practice. What makes our job particularly challenging is distinguishing the more sinister necrotizing soft tissue infections from the more common, less severe ones. So, to kick things off, can you provide us with a concise overview of what necrotizing fasciitis is?
So, necrotizing fasciitis is an infection that is rapidly progressive and life-threatening, involving the deep, soft tissues. It involves the fascia and subcutaneous fat, leading to fulminant tissue destruction. Unfortunately, it has a high mortality due to its delayed recognition and treatment.
Perfect, Aurnee. And that's a very sobering description that really highlights the importance of swift recognition and intervention. So for our listeners, can you break down the various types of necrotizing fasciitis that clinicians should keep in mind?
There's two main types and also a subset of necrotizing fasciitis. There's type 1, which is a polymicrobial infection. This involves aerobic and anaerobic bacteria like Bacteroides, Clostridium, and Streptococcus. It's common in immunocompromised patients or those with comorbidities such as diabetes and peripheral vascular disease. Then there's type 2. These are monomicrobial. Usually these are caused by group A strep or Staph aureus. It can occur in otherwise healthy individuals. And then there's also pathogens like Vibrio vulnificus, which can occur after water exposure. Then, like I mentioned, there's also a subset, Fournier's gangrene. This is necrotizing fasciitis that specifically affects the perineal, genital, and perianal regions. It's often seen in patients with diabetes. This subset of necrotizing fasciitis carries a higher mortality rate, especially in females.
Perfect breakdown of the different types from polymicrobial to monomicrobial and the subset of Fournier's gangrene, along with the key risk factors. Now that we have a good grasp on the what and the who, can you explain the underlying pathophysiology of necrotizing fasciitis and clarify who's at greatest risk here?
So, necrotizing fasciitis is infection that spreads along the fascia due to poor blood supply in these areas. Tissue ischemia is often exacerbated by vascular thrombosis, which leads to rapid necrosis. Patients most at risk are those with diabetes, especially those with vascular compromise. Anybody who's had recent surgery or trauma, as breaks in the skin can introduce bacteria into the deep tissue layers. Immunosuppression due to medications or diseases like cirrhosis and malignancy. And then also, it's important to note that any patients who are using NSAIDs may have a delayed diagnosis because they may be masking their symptoms.
Yes, and this gets at that underlying theme that this is a tricky diagnosis and it hinges heavily on gathering a thorough history and recognizing those risk factors. Now, can you walk us through the clinical presentation and specifically what symptoms and signs should we be looking out for on physical exam?
Early symptoms usually involve severe pain, especially pain that is out of proportion to physical exam findings. You may also see erythema without clear borders, and patients will often have fevers or have malaise. There's rapid progression of these symptoms, and then we can see skin color changes from red to purple, formation of bullae that are filled with fluid, and development of skin necrosis and gangrene. You may also have presence of crepitus in polymicrobial cases. The late-stage signs include systemic toxicity. You can see hypotension and multi-organ failure if this infection is left untreated.
Yes, absolutely. And detection is crucial here. Catching these infections at the earliest stage can dramatically improve outcomes. So once we suspect neck fash, can you walk us through the key diagnostic steps that confirm the diagnosis to the best of our ability and assess the severity of the infection?
This is really a clinical diagnosis. It's important to rely on your physical exam findings. You'll often, like I said, see pain out of proportion on the exam. There's also something called the finger test. This is done by making a small incision in the affected tissue and kind of going down into the tissue planes to see if there's any purulence. You also want to involve surgery as quickly as possible. They need to cut down and see what the fascial planes actually show. There's also laboratory testing. You can get labs and calculate something called the L-Rinic score, which relies on CRP, white blood cell count, hemoglobin, sodium, creatinine, and glucose to stratify risk of necrotizing fasciitis in patients that you're concerned about. While this can be helpful, it's not a definitive diagnosis. And then lastly, there's imaging. If there's time, you can get a CT scan for these patients. Oftentimes in CT scans, you might see gas in tissues, fascial edema, or muscle involvement. However, it's important that getting this imaging does not delay surgical intervention. That comes first.
Yes, and it's quite the complex diagnostic journey that's heavily reliant on clinical suspicion and a solid physical exam. Now, ultimately, direct surgical exploration is the gold standard to confirm neck fascia. So while labs and imaging can help guide us and might even satiate the curious consultant, they're not definitive, and we mustn't delay surgery if we suspect this condition. Now, once a diagnosis is made, Aurnee, can you outline the core principles of treatment?
Surgical intervention is the definitive treatment for patients with necrotizing fasciitis. They need immediate and aggressive surgical debridement of the areas that are affected, often to skin that's healthy tissue. They may need to go back multiple times for surgeries because there may be tissue that has ongoing necrosis. Then there's antibiotic therapy. These patients need to be started on antibiotic therapy as quickly as possible. Usually, empiric therapy includes some sort of MRSA coverage, either with vancomycin or linezolid. And then there's piptazo and carbapenems, which are used for gram-negative and anaerobic coverage. And then lastly, clindamycin is usually added to inhibit bacterial toxin production. These therapies can be adjusted once cultures come back, but these are generally where people start. There's also adjunct therapies like hyperbaric oxygen therapy. This can be considered in patients who are not responding well to standard treatments. However, this may not be available where you are, and there's mixed evidence about whether or not it's beneficial. And then lastly, and maybe most importantly, these patients need supportive care. They're going to need intensive monitoring in a critical care setting. Often they need fluid resuscitation and vasopressors for septic shock.
Yes, solid plan. Start with antibiotics early, stabilize hemodynamics, and get surgery on board as soon as possible. Now, if available, hyperbaric oxygen therapy could be an option down the line, but this is going to be controversial, like you said. And as for disposition, there's really no question these patients are going to be staying in the hospital and going to the OR. But from a patient and family perspective, what can we tell them about the prognosis and the road to recovery?
So I think it's important to acknowledge that these patients do have a high mortality rate. This is often affected by several factors, including where the site of the infection is, what the patient's baseline health is, and then how quickly the diagnosis is made and how quickly intervention can be started. Early and aggressive treatment improves survival rates in patients. And it's important to emphasize that these patients will often need extensive rehabilitation and may need reconstructive surgery during their long-term recovery.
Aurnee, very good. We went over some meat and potatoes of neck fascia. Let's go over some take-home points. Necrotizing fasciitis is rapidly progressive and life-threatening. Early recognition is critical for improving outcomes here. And there are going to be different types. There's going to be type 1, which is polymicrobial, which can affect immunocompromised patients and diabetic patients, while there's type 2, which is monomicrobial, and that can appear in otherwise healthy individuals. Now, the definitive diagnosis relies on clinical suspicion, physical exam, and that finger test, the cut down, the surgical exploration, which are paramount here. Labs and imaging, they can support the diagnosis and our suspicion, but never let it delay necessary surgical intervention. Next, early and aggressive surgical debridement coupled with broad-spectrum antibiotics covering both gram-positive, gram-negative anaerobes, this is essential. And it's recommended that we add on clindamycin to reduce toxin production. And finally, necrotizing fasciitis carries a high mortality rate, but we know that early intervention improves survival, and extensive rehab and possible reconstructive surgeries are often needed, underscoring the importance of prompt, coordinated care here. Okay, that'll do it for this episode. Aurnee, thanks again for being on the podcast with us.
Thanks for having me.